Welcome to tonight's webinar, Beyond GLP Drugs, Natural Ways to Support Metabolism and Weight. We're pleased to feature Dr. Eric Nelson, a naturopathic doctor here at Nirvana Health, whose clinical work focuses on metabolic and cardiovascular conditions, regenerative medicine, and men's health. Dr. Nelson, I'll let you take it from here.
Awesome. Thanks for the intro. It's interesting because the title is very much split. It's very much like this is only going to be, we're going to talk mostly about naturopathic medicine and natural approaches to weight management, but I actually will have quite a bit to say about GLP-1 medications because they are misinterpreted in the lay public and the general population. So just want to make sure that people can frame where they can put them in their mind, when they might want to use them, and when they might not be the best case for you. GLP-1s are something that I probably talk to my patients about pretty much every day, simply because it's a very interesting topic to discuss, and a lot of people have questions and concerns about them, and or they're using them therapeutically, and they want to know about managing side effects and how they work and how they can get off of them if they want to get off of them in the future, and what does that all look like. So we'll just dive right into it. And I kind of wanted to start this whole talk with an analogy. And so I like to think of it as the water source analogy. So I want you to consider which one of these two water sources that you would prefer to get your drinking water from. Right, so everyone's going to go up, look at the top left-hand corner there. You can see it's a beautiful mountain stream, probably very close to the actual mountains themselves. This would be glacial runoff. It's really pristine water. So if you could imagine that your entire metabolic health, which would include your weight, your body fat, your body composition, and your metabolic health, which includes your blood sugar control and your cholesterol and your hypertension and blood pressure, if all that mattered was the quality of the water that you were drinking, you would prefer to take that really beautiful mountain stream right there, right? If you look down at the polluted water, this is to describe that some people are born with very unfortunate water sources, meaning like they have unfortunate genetic makeup, family makeup, an environment that they're born into, or an environment that they're surrounded by that pollutes their water source. So they're trying to drink from this water and trying to stay healthy, which can be a tall task. It's nearly impossible in some scenarios. So I just wanted to put that in your mind, as we can, as a society, try to move towards a healthier water source globally, right? That's the ideal scenario. But in the meantime, in our current environment, we're getting actually further and further away from the mountains. We're getting closer to a stagnant, swampy lake, so far away from the mountain that's been polluted with litter and plastics and all that stuff. And the problem here is that we all have to work harder and harder and harder to maintain our metabolic health and our weight. Now, some people, this is much harder than others, but I want you to think of GLP-1 medications really like the LifeStraw in this scenario. And I'm going to talk about the LifeStraw. If you're not familiar with the LifeStraw, I'll talk about that as we go along here. But what I want to just describe is what determines your water quality. And by water quality here, it's your metabolic health. It's your weight, right? And so the best available literature is showing that at least 60% of your metabolism and your current weight can be tracked back directly to genetics, aka what you were born with. About 40% of it is everything else. And some literature goes up higher than 70%. If you look at twin studies, it might even be higher than 70%. But at the very conservative level, about 60% of what dictates somebody's weight is genetics. And there's a lot of reasons why, even though genetics haven't changed a lot over the last 100 years or 200 years, the net result of obesity crisis and overweight and metabolic health issues like type 2 diabetes have exploded. And so it's a misnomer. You kind of think of being, how can genetics be so important here, but also there be such a difference in our metabolic health results of 100 years later or less, right? So the everything else category is what we all think about. This is what we spend our time talking about it as naturopathic doctors. We talk about diet, we talk about home environment, we talk about health habits, we talk about cooking skills, even finances can play a role, exercise, of course, friendships, hobbies, your job, mental health, environmental pollutants. We spend a lot of time talking about the things that we can control, right? Because we can't do much about our genetics. But the point being is that most of us have to work really quite hard in our current obesogenic environment in order to maintain our weight and our metabolic health. We have to be disciplined in some way, shape, or form so that we can be consistent with our workouts and we're getting the right food into our homes. And therefore when we're hungry or bored or we're irritable or we're stressed, we're searching for and we're grabbing healthier food options. But it takes a lot of effort. And there's certain times in our lives, whether that's, a loss of a loved one, going through menopause, going through some sort of a divorce, that it's very unlikely that we are going to keep up that same diligence, and therefore we can gain weight. And oftentimes that's how weight gain actually happens over the years, is that you have specific things happen, you gain weight during a period of time, you find a new baseline, your brain loves that new baseline, and then it protects it at all costs. And then it basically just lets you live your life until your next traumatic event life happens, or something throws you off your rhythm, and then you could potentially gain more weight. And if you look at the life cycle, people tend to gain weight in very specific time blocks in their lives. It's usually right after high school when they stop playing lots of sports. They go into more of a sedentary environment, oftentimes with a lot of drinking. In a college setting, they get their first job and they're very sedentary. A lot of people will gain weight there. And then again, once people have kids, if they do have kids, oftentimes there's a weight gain that's somewhere in the 30s to 40s category. And then often menopausal or perimenopausal states when you're if you're a female. And then age is around 65 years old for both men and women is actually the most obvious time point in which weight gain is likely, right? Not guaranteed, but very likely. Now, so what I would say here is that our obesogenic environment currently, this is what's changed. So our genetics haven't changed, but this has changed so much that it made people that just had a mild or a modest genetic risk for obesity or type 2 diabetes, for example, and it's laid it bare. It's made it very obvious. It's made it nearly impossible to fight unless you become a hermit or you move to Japan or you go somewhere else. But in our current environment, we are flooded with ultra-processed foods, right? Foods that essentially never expire. They're full of very delicious products, sugar, fats, salt, artificial flavors, emulsifiers, things that make them feel good on the tongue, make it difficult or nearly impossible to stop eating. And then, of course, it's ubiquitously available. You go to any store, you have processed foods in your face. You go, essentially, even if you don't go to the store, you can just have it delivered to your door really quickly, DoorDash, right? You can have these foods, whether you're lining up at a fast food, you're in the hospital, you're at a school, you're filling up your gas tank, pretty much these are available. They're ubiquitous. And the increase in the amount of calories that we are putting into the food system is more than enough to explain the entirety of the obesity epidemic. Meaning that the food system, the available calories that are available per person has increased well over 700 calories per person per day, which can explain the difference in our entire, as a society, our weight between the 1970s and now. Now, of course, high amounts of stress, lack of physical activity, poor sleep, endocrine disrupting chemicals found in everyday products, things you put on your skin, you put in your mouth, you drink in your water, even social cues and norms. So just what we think is normal, how we think about food in terms of a means to celebrate, a means to deal with stress, as a means to deal with breakups, as a means to, essentially we think it's normal to utilize very highly processed, very hyper palatable foods as a way of rewarding ourselves. And that's a big part baked into our culture. So our culture, our environment is literally obesogenic, right? So, or obesity generating. Now, the GLP-1 medications, the way that I want people to frame this is like, we didn't actually fix the problem, which is the water source. The water source is getting more polluted. But we can give people medications. These GLP-1 medications are like having a LifeStraw in your pocket. So you can go and you can suck out some of that dirty water. It filters it for you. You now have a fairly high chance of having good metabolic health with these medications. That includes your weight, of course. Now, so that's how I want you to think about it. It does not fix the systemic problem, but they are an excellent Band-Aid solution. Okay, so we still, as a society, need to consider, is this the water we want to feed our kids? how can we improve this? How can we improve the school food system, right? How can we improve our own home environment where our kids grow up so that our water sources that they are drinking from don't require a LifeStraw at age 18 or age 16 or age 20, right? I'm sure you can understand that these medications, they have a role. They do probably save lives, yet they are also sidestepping the problem altogether, okay? Now, so what are GLP-1 medications? Let's talk about these. So the GLP-1, GLP stands for glucagon-like polypeptide 1, and GIP, which is glucose-dependent insulinotropic polypeptide. They're both gut hormones. So they're naturally produced in response by specific cells called L cells in your GI tract. They're produced in response to essentially fermentation of food. Okay, it's not only fermentation, but essentially you can think of it like you consume food, you have some of that is fermented, some of that directly. Basically, it's a mechanism by way of your gut talking to your brain to tell the brain what is going on. And so these gut hormones have an effect on hunger, and they have an effect on whether or not you feel full, for example. And they're generally quite health promoting. They help the liver do their job, they help the pancreas do their job. Their primary role, in fact, is to talk to the pancreas and the liver. So our natural GLP-1 production, which we all are producing, only lasts about 1 to 2, maybe 3 or 4 minutes. But most studies show 1 to 2 minutes. That's as long as it lasts for. It gets utilized really quickly and it gets cleared from the bloodstream. GIP is a little bit longer at 5 to 7 minutes. But you can think of these normal gut hormones, which we are all producing. It's very helpful. They are limited in their overall effect because of their short half-life. They get metabolized and they get removed very quickly. Now, just as interesting side note, this is a beautiful little lizard creature. This is called a Gila monster. I lived in Arizona for 6 years. I got the privilege of seeing this one time. They're really hard to find. But interestingly, this entire class of medications started with a poison that is extracted from the Gila monster. And this Gila monster poison basically made it so that GLP-1 would stick around for a longer period of time. Okay, and so of course the Gila monster poison has a much more in it than just GLP-1 receptor agonists, but this component of this venom was found by a scientist named Dr. John Ng, and he recognized pretty early, this is in the early 1990s, I think 1991, he recognized that this would be pretty useful. He patented it, and he tried his best for the next 13 years to get it in the hands of somebody that could turn it into a therapeutic drug. Now, the first thought here, the first drug was launched in the US in 2005. Now, that first drug, though, was really meant for type 2 diabetes. So type 2 diabetes, that was the original thought process here. And it wasn't until much later that we talk about the weight loss indications of this. So I'll go into that. Actually, I'll come back to this slide that talks about how the medications work. Now, it's discovery. I'll talk a little bit more about the discovery here. So GLP-1 hormones, and I apologize if I'm going fast through this, but I wanted to leave enough time for questions at the end. So GLP-1 hormones we knew that there was something that was being produced in the gut that was having an effect on the brain, speaking to the brain and speaking to the liver and speaking to the pancreas. And we knew that was happening from the early 1900s, but they didn't know what was going on. The first gastric peptide was GIP that was actually discovered and isolated, and that was in the 1970s. GLP-1 was slightly after that, closer to the 1980s, late 1980s. But it wasn't turned into a medication until, like I said, 2005. Okay, so exenatide and then I think liraglutide was approved in 2007. So it still has been roughly 20 years since those first two GLP-1 receptor agonists have been on the market. And those were originally approved for type 2 diabetes. And the reason why it was approved for type 2 diabetes is that these medications, they tell the pancreas to produce more insulin. That insulin is essentially, you get more insulin, so you are very likely to control the liver's production of glucose, and you also decrease the amount of glucose or blood sugar that's floating around the bloodstream. Okay, so that was the use cases for diabetics. These first two drugs really only had about a 1 to 2, maybe 3% weight loss on average. for this for the patients. But the main downside to these medications is that you have to inject them every single day. Exenatide, you have to inject twice a day. Liraglutide was a big improvement because you only injected it once a day. But they had quite a bit of side effects, a lot of the same side effects I'll talk about soon with the current medications, but they were more intense and you had to deal with them every day because you had to inject every day. 2017 is where semaglutide came on the market. This is Ozempic, right? So Ozempic, most people were familiar with semaglutide, not in 2007 when it was approved as a diabetes medication, but in 2021 when it was approved for weight loss. Yeah, so Ozempic is actually the drug that is marketed for diabetes. Mounjaro is used for weight loss. So tirzepatide, this is the next generation. We'll just talk a little bit about these in the future slides here, but 2017 all the way up to 2004, these are the current crop of GLP-1 agonists that are on the market. These are what people are using. This is what is leading to weight loss and significant improvement in metabolic health. There is a ton of activity in this entire field, of course. The main things to note here is that Canada is the first country in essentially developed nations that is allowing generic semaglutide or Ozempics on the market. And I think that approval is pending, could happen tomorrow. It's going to be very, very soon. So there's going to be generic versions of these drugs, which should make them very cost effective. There's oral versions of these drugs as well. And then there is additional formulations that might only require an injection once a month or even less. So just a little note here is that currently, as it stands, based on diagnostic criteria for these drugs, is over 70% of the Canadian population could be considered eligible for them right now. And that criteria is based on essentially BMI, which is a marker of weight, plus a consideration around metabolic health. So if you have a BMI above 30, you qualify. If you have BMI above 27, plus a metabolic concern like hypertension, insulin resistance or prediabetes, or PCOS, for example, or obstructive sleep apnea, those things can increase your likelihood that you're going to be eligible and get covered for these medications. I'm going to circle back. So how do these things actually work? Now, GLP-1 medications, the big effect that people talk about is the gut effect, right? So it's this slowing of the gastric emptying. So it basically slows down the entire GI system to the point that the food moves through you so slowly that you often will feel full very early and you'll feel full for longer, right? Now that, of course, if things are moving through you very slowly, that of course changes your microbiome. And I'm happy to talk about that later as well. But it changes kind of what foods that you should be able to tolerate, how much of it you can tolerate, how often you can eat comfortably. And you get this sensation of fullness quite a bit early. Now, where the weight loss actually comes from is minimally related to the gut. It's mostly related to the brain. So the effect on the parts of your brain that regulate physiological hunger, so your drive for food, and then also psychological hunger, which is essentially described as food noise, it quiets both of those down. So you get less reward for eating hyperpalatable foods, and you are more likely to just not have the hunger in the first place. So when people are on these medications and they're working, the real effect that a doctor is looking for is simply a reduction in appetite that allows them to stick to the diet and lifestyle recommendations that were already prescribed. So it's people that are already trying to do the right thing. The target of these medications is to help their brains feel more comfortable with quote unquote doing the right thing. Okay. Now these GLP-1 medications, every single week there's another study that comes out saying, hey, there's another compound or another part of the body that GLP-1s are acting on. So I think this is still to be determined, but there certainly is an effect on the liver directly, on the pancreas directly. There probably is an effect on metabolism directly through what's called brown fat. It's pretty minimal, but it still is there. It's really interesting. These medications obviously cross the blood-brain barrier. They have plenty of effect at the brain, but it's this crosstalk between the liver, the gut hormones, and the brain. right? So all of this is changing all at one time. Now, it's important to know how these work because they also describe your side effects or your likely side effects and what things to watch out for, okay? Now, moving down to the current crop, the 2 medications that you're going to hear all the time, this is the semaglutide, which is Ozempic, Wegovy, Rybelsus. Tirzepatide is Mounjaro and Zepbound. I think I said that incorrectly earlier, but Ozempic, Wegovy, Rybelsus, this is the one that's a little bit older. It's been on the market since 2017, like I said. It changed the game because instead of having the previous medications you had to inject once a day, semaglutide lasts in the bloodstream for it has a half-life of 7 days, which means that it's in the system for much longer than that. But it's at a clinically high enough threshold where it will be suppressing your appetite for roughly a week. And the starting dose for this one is really, really low. It's 0.25s, which is the lowest dose you can get it as Ozempic. And at that dose, really interestingly, you should not see any weight loss. It's considered a subclinical dose. The intention there is to get the body used to the medication with very minimal side effects and then titrating up slowly over time with obviously the doctor, prescribing physician, monitoring that for safety and making sure that the patient is tolerating it well. So that's one. The interesting, people get these mixed up, but they're literally the exact same compound. Ozempic was approved for diabetes. Wegovy was approved for weight loss, but it's the exact same compound, just different doses. Rybelsus is an oral version of this. So it's a capsule. It's not quite as effective in terms of weight loss, but it's pretty similar. It does have more GI related side effects than the injectables. But I think a lot of people actually do end up using these over the long term for maintenance. Now, tirzepatide is also known as Mounjaro or Zepbound. Mounjaro is the one that's approved for diabetes. Zepbound is the one that's approved for weight management, but it's the exact same medication from the exact same company. The difference between these two is that tirzepatide acts on 2 gut hormones. It's the GLP-1 and the GIP. So semaglutide just on one, the GLP, is tirzepatide on GLP-1 and GIP. So it has a greater effect and interestingly has a lower side effect profile when compared to semaglutide. So in the US last year, the shift from semaglutide to tirzepatide was dramatic. So the amount of people that are shifting towards tirzepatide, I would say it's going to be more rapid in the future once more insurers start to pay for this. But in Canada, this is something, tirzepatide, you're going to see very commonly is the one that your doctor is actually recommending right off the bat. Interestingly, one of the main reasons why they do that is because when you start on the lowest possible dose of Mounjaro, which is 2.5 milligrams per week, you can get weight loss with that. And some people never have to go up. That's the only dose they ever need, which is pretty amazing. And the amount of weight loss, just FYI, to put these numbers into perspective, because a lot of people this doesn't mean anything. But if you are 200 pounds, right, and you lose 10% of your body weight, that's 20 pounds. If you lose 20% of your body weight, that's 40 pounds. So you go from 200 pounds to 160 pounds. That, if you lose between 10% and 20% of your body weight, in the majority of cases, you can reverse or put into remission type 2 diabetes. You can reverse or put into remission non-alcoholic fatty liver disease. So a lot of the metabolic conditions that go along with excess weight can be reversed or put into remission with the normal standard dosing protocols with either of these 2 medications. Okay, now I'm going to move on. So let's talk about side effects. This is what everyone wants to know about. There's an article about this, in General Pop article on this pretty much every day with a new side effect that you got to be aware of, whether that's Ozempic face or Ozempic butt or something along those lines. Medically speaking, the 3 most important side effects fall into these buckets. They're the 3 most important buckets of side effects are muscle loss, gastrointestinal issues, and dehydration-related symptoms, okay? So gastrointestinal symptoms or issues, those are pretty obvious. It's the relationship between the slowing of this system and often people not having a good match between what they ate and what their system can handle. So nausea, vomiting, constipation, or diarrhea, gas, bloating, increased SIBO risk. There's all sorts of gastrointestinal issues that are quite common with these medications, but not necessarily expected. And in my opinion, if you're dosing these correctly, you should experience very limited amounts of these things. You will probably have to play around and learn which foods work well with these medications and which dose you should be on, essentially which medication and which dose you should be on. Now, the one thing to note about gastrointestinal symptoms is there is an expected symptom that is, I would say, so common that it's almost preferred that you have it, so we know that you're getting the right medication and the medication is doing something. But it has to do with basically that sensation as if you just sat at Thanksgiving dinner and you ate way too much food and you're sitting at the table and you're unbuttoning your pants and you're going, I don't even want to look at food right now. It's the sensation that's like the queasy sensation. It's not really nausea, but it certainly is a sensation like you are so full you don't want anymore. And that's actually fairly common with these medications. Only in the first couple of days. So you inject 1 or 2 days, you have those symptoms, and they typically would taper off. Now, the other symptoms over here, I'll just quickly talk about dehydration, but it's very common for people to not just lose their appetite with these medications, is you can also have a blunting of your thirst. So if you're obviously thirsty but you don't know it, you're blunted that response to your brain, you're often going to under eat or under drink. And then also if you're eating fewer times per day, you often will be drinking less as well. So headache, dizziness, fatigue, lightheadedness, flu-like symptoms are all possible with these medications, and something that you want to be aware of so that you can prevent it right off the bat. Muscle loss and sarcopenia. So muscle loss, I think, is the most significant risk of these medications, and it's almost 100% preventable if you do these medications correctly. And I'll talk about how to do them correctly in the future here, but I will just circle important list of less common but real concerns that you need to talk to your doctor about, including pancreatitis, certain gallbladder disorders, a very specific eye disease that can draw blood flow to the back of your eye, 2 specific types of cancers or a family history of those 2 types of cancers, and then stomach paralysis or what's called gastroparesis. So these are very real. They're not very common, but still you have to talk to your doctor about these things. They have to know if you have a family history or a personal history of these concerns. They got to know if you have a gallbladder in the first place. And of course, these medications can also interact with anything that you swallow, right? So supplements, medications, obviously the food you eat, alcohol, drugs that you take through the oral cavity, edibles, for example, there is an effect. So you have to know that when you're on these medications. How am I doing for time? 7:30, my gosh. So I wanted to talk, just to dig in a little bit more about sarcopenia, which is the loss of muscle. Okay, so muscle is essentially our greatest metabolic asset. So having a good amount of muscle is protective against most metabolic disorders. Muscle is what's called a glucose sink, so it helps pull blood sugar into the muscle and you can burn it as a fuel. It can also do the same thing with fatty acids in the form of triglycerides. It is helpful for function and stability and mobility as you age. Obviously, it's important. It's also an endocrine organ. So muscle literally produces hormones that will go and cross the blood-brain barrier, have an effect on things like depression risk and Alzheimer's and dementia and all sorts of things. So you want to protect your muscle mass pretty much at all costs. So the primary problem with these medications is that if you lose weight and you lose weight too fast, you will lose muscle. And if you ever go off these medications, you are very likely to gain the weight back and you will not regain the same amount of muscle back that you lost. Now, to be fair to the medications, this happens with natural weight loss as well. You have incredible success with intermittent fasting or full-on fasting or whatever type of dietary approach you ascribe to. If you've lost weight and it's been too rapid, you're very likely losing muscle along the way. And if you weight cycle, which is what this graph is describing, you can end up in a worse place. So this is describing starting at 200 pounds, losing weight, that's 20%, gaining back all the weight, okay? 200 pounds, 160, 200 pounds. Looks like, oh, you'd be all good. But if you started at 30% body fat, you drop down, this is a 50% weight loss, body fat percentage wise, and then you go back up. If 80% of what you regained was fat, which is, this is the norm. This is not exception, by the way. So unless you were losing weight while doing a good amount of strength training to protect your muscle mass, you're probably losing muscle mass along the way. Okay, so the prevention here becomes so important on these medications because not too many people get prescribed these and they don't follow through with the prevention strategies that help maintain their muscle. And if they ever want to get off the medication, they have to have the muscle, okay? So the first thing is, if you're on the medication, controlling the speed. So if you have too high of a dose and it creates essentially, if it suppresses your appetite too much, it will create too much of a caloric deficit and you will lose muscle too quickly. Number two is, if you're not resistance training, you're not strength training, you're not lifting weights, without a stimulus on the muscle, your brain does not care to keep it around. It is metabolically expensive. It is happy to get rid of the extra muscle in favor of making sure your liver has enough and your kidney has enough and your brain has enough and your heart has enough. So your organs will take preference over your muscle. So resistance training is a stimulus. It's the strongest stimulus here to maintain a signal to the brain that you think this muscle tissue is valuable, you need it, you want to keep it, right? Protein intake. Now, adequate protein, this is something that is super popular right now. It's actually overblown, in my opinion, in the lay public, so in the general public that are not on these medications. The protein intake targets I think right now are getting a little bit outrageous, but it is actually very challenging to eat enough protein while on these GLP-1 medications if you're not consciously thinking about these things, because your appetite is suppressed. The amount of food you can handle at one time is suppressed. A lot of the times the protein-rich foods fill you up so quickly on these medications, it can be challenging without any type of supplement to reach the required protein intake that would be a stimulus to the body to say, keep this muscle alive, keep it here, okay? So the general protein intake target is around 1.2 to 1.6 grams per kilogram. If anybody says anything above 1.6 gram per kilogram, there's no way that somebody with the GLP-1 medication is getting there anyway, so it's unrealistic. So I think 1.2 to 1.6 is a great target. Now, best practices for weight management. I wanted to shift gears. Obviously, I want to talk about just weight management in its entirety. So weight management, the main things here, and the best practices here, it's just easier said than done, but number one is understanding yourself, okay? We all have unique personal histories, preferences, taste preferences, social environments, friend circles, hobbies, habits, right? And so a lot of our days are unconscious. We are going through the motions. We are eating foods because it is there. We struggle to stop overeating specific foods, right? Some people have sweet tooth, some people have a salty tooth. All of that stuff actually matters way more than you think. People can spend a lot of their day thinking about, oh, I did all of the things right. But it was actually that 5 minutes or the 10 minutes or the 30 minutes, maybe at the end of the day, where they sabotage their entire day. Or maybe they sabotage their entire week, on a Saturday night or something. And so you have to know what works for you. Is it high carb? Is it low carb? Is it high protein? Do you have to absolutely get rid of specific foods from your house? Do you have to stop hanging out with certain people? Do you have to completely get rid of alcohol? This stuff actually matters way more than most of the other things on the list. So are you eating? Are you overeating? Just take note. Are you overeating because you're nervous, you're stressed, you're bored, you're angry, you're irritable? Because you're around some specific person, because it's in the house, because it's in your face, right? There's a lot of reasons why we eat that have nothing to do with hunger or motivation or drive. Now, set realistic goals. I think whether you're using a medication or not, 0.1 or 0.5 to 1 pound of fat loss per week is excellent and plenty. And if you're going above that, you are either losing a crazy amount of water, which is very common at the very beginning of doing a dietary change, for example, or you're losing muscle. So if you lose 5 pounds and 3 or 4 of those pounds are muscle or lean mass, That's not good. It's not helpful. So what you're looking for is losing fat. And that is you have to work with your body here. You actually cannot exceed, I would say 2 pounds per week on the high end, but 0.5 to 1 pound per week of fat loss is a great realistic target. And then, of course, talk to your doctor, determine if medication is appropriate for you. This is obviously part of the topic today. Track body composition. I'm a big believer in this, is that the weight on your scale is not really reflective of much. It's more of the body composition. So it's the percentage of your total weight that is body fat and the percentage of your total weight that is muscle or lean tissue. And if you don't know how to find a body composition, this is something you can look into your local environment. There's gyms that have devices. When the clinics I work at has the devices, you can get DEXA scans, you can get MRIs. There's a lot of ways to do it. But my preference is for you to actually pay attention to those numbers and not so much the number on a normal plain weight scale. And then prioritize resistance training. This is absolutely like a non-negotiable for me, because specifically if you're trying to lose weight, okay? You're not using resistance training to lose weight. You are using resistance training to maintain muscle while you lose fat, okay? Exercise alone is a terrible way of losing weight in 9 out of 10 patients. So there's always going to be 1 out of 10 patients that all they did was they increased their exercise, they ended up losing weight. Usually this is a relatively young male. Older patients, females, it's almost never the strategy that works long term. So you prioritize exercise because it is good for you. It is great for your mental health, your cognitive health, your physical health, your metabolic health, and it maintains skeletal muscle mass as you are using other tools and or diet to lose body fat, okay? Best practices for GLP-1 medications. So if you're using these medications, the main thing down to the bottom, this doesn't change at all, prioritize resistance training. So I just talked about that. It's absolutely required. But the main things you want to consider here is you got to adjust your eating patterns. So typically that means reducing the size of the meal. So smaller meals, you eat them slowly, you space them out more. Most people will have to avoid specific trigger foods. So one of the most common causes of diarrhea on these medications is that you had a fatty meal. A good chunk of that fatty meal goes through the system undigested and then gets to the large bowel and causes diarrhea, right? The same thing for excessive gas, bloating, cramping, abdominal pain, and sometimes constipation is it could be related to undigested food that gets fermented and then you get symptoms from that. So avoiding trigger foods and not eating right before workouts, not eating right before bedtime are all really important strategies. Prioritize protein. This is just a conversation around, probably like the way that I would recommend is just eating your protein first within a meal. It doesn't have to be a huge portion, but you should make sure you're getting that at least the floor of 1.2 grams per kilogram body weight of protein in a day. And you usually eat it first in the meal, because if you get full too quickly and you haven't eaten any of the protein, then you're going to be in a sticky situation. I also think that it's really important to consider the use of protein supplements during this time frame if you are using these medications, because whole food proteins are quite filling. Number 4 is time injection strategically. So this is a little bit of an advanced tip, but if you are injecting and the medication has its strongest effects on your appetite in the first 2 or 3 days, it might be smart for you to inject, Thursday night, and then now the Friday and Saturday nights that you have a difficulty with social eating or whatever, that would be the time when the medication is strongest and you're going to blunt your appetite and have less desire for those things. And when the medication is wearing off, let's say Wednesday evening, it's the least amount of activity. You don't need the medication as much because you might be at home, more controlled environment, right? So this is just timing injections does matter. You got to actually talk to your doctor about this one, of course. Now to the fun part here. So natural GLP-1 medications. At this point, if I could see you guys, I would put my hand up and say, who's heard that berberine is nature's Ozempic? Berberine is classic. It does have a GLP-1 effect. It's quite a strong effect, but it is engaging / increasing natural GLP-1 production, okay? So our natural GLP-1 will still get degraded within a few minutes. So even though there are plenty of natural GLP-1 agonists, and most of these are really smart things to bring into your diet anyways, because they're associated with improved metabolic health regardless of weight loss. You should be increasing these things, but the thing is, you have to eat them regularly, pretty much all day, and you have to have a high enough dose of these things to make an effect. So the GLP-1 stimulation, the agonist, the things you'll see on supplements that are marketed to you as a natural GLP-1, you have to know that it is true, but limited in its effect. It's not going to have the same effect on your brain, specifically your appetite reduction, as a medication will. In fact, it's roughly 100-fold less activation at the level of the brain when you're using these natural therapeutics. But I really like, and I almost always prescribe these. So with all these said, resistant starch, if you haven't heard of resistant starch, this should be your new best friend in 2026. Resistant starch is basically when you cook any type of starch. This could be rice or potatoes or quinoa or whatever, and then you cool it. A good amount of that starch will turn into what's called resistant starch, and it is resistant to your digestion, but it acts as a fiber. So it is a great prebiotic for your microbes to turn into really healthy things. And certain production, specifically things like butyrate and acetate, will be produced. And both of those things stimulate GLP-1 naturally. And interestingly, if you think about it this way, if you can curate the right microbiome to produce butyrate and acetate for you all day long or for hours after a meal, you are slow dripping GLP-1 into the system, right? So yeah, it gets degraded quickly, but it's coming in constantly. So I really like that approach: soluble fiber, resistant starch. Bitter foods and herbs. So bitter foods, literally anything that stimulates the bitter receptors in the mouth and in the GI tract. And yes, you have those receptors all the way through the GI tract. It's not just in the mouth. If it's a bitter food, often, or a spice or an herb, often it will stimulate GLP-1 production. This is one of the reasons why many of these foods will improve glucose response, because they produce a little bit more insulin, and your liver and your pancreas work a little bit harder, and typically it can control the spike that you get after a meal. Yerba mate, matcha, black tea, green tea, in terms of drinks, they've all been shown to have GLP-1 agonists. We all know that they're very healthy for you from a cancer perspective, metabolic health perspective. ECGC by itself has been shown to improve diabetes and blood sugar control. So I'm a big fan of these not medications, but foods and teas and functional foods and supplements, whether you want to get it as capsule. Vinegar, I should have had a whole slide on vinegar because it's so cool. If you've been paying attention to the natural therapeutic space, like apple cider vinegar, or any type of vinegar, technically acetic acid is the active ingredient. Any type of vinegar has a weight loss benefit. And really interestingly, it has the weight loss is predominantly in the liver, in the visceral fat, in the area where you need to get rid of fat, right? So it's the area where fat is the most toxic to the body. And so vinegar has been shown consistently, trial after trial, to have about a 1 to 3% reduction in body weight. And a lot of that comes out of the liver and the visceral organs. Now, so the interesting part about the vinegar is that it doesn't matter which type. It's apple cider, it's balsamic, it's rice wine vinegar, or red wine vinegar, or white wine vinegar, or rice vinegar. Doesn't matter. It's the acetic acid. And the acetic acid is the same thing. It's the acetate there that stimulates the GLP-1 production. So it's the same thing as when you eat resistant starch. And that's producing acetate, and that's stimulating GLP-1. They work similarly, differently obviously, but similarly. Cayenne pepper, spicy foods, those have a known GLP-1 agonist effect. The compounds called phycoloids, which are from green leafy vegetables also. Now, I think people should incorporate these regardless, right? If you can handle these foods and you like them and you enjoy them and you can get a wide, diverse array of them, they should be incorporated. And it might be one of the reasons why people that eat more, Mediterranean or plant strong, typically have lots of these foods, and they often have lower weight, right? So, and improved metabolism, very lower risk of diabetes, for example. Now, second last page here. I'm bang on time here. So I really want you to kind of circle back to the water source analogy here, which is, yes, you can use the LifeStraws. They do work. They can be dosed appropriately in most people so that they're very well tolerated, they're effective, and all that stuff. We talked about some caveats. Yes, most people stay on them for life, and we'll talk about that if anybody has questions about that. It is possible to get off of it, especially if you had weight loss that was due to a very specific thing like a divorce or a loss in the family or something like that. But what I recommend here is for people to think about their water source that they're drinking from, that their kids are drinking from, that their loved ones are drinking from, okay? So it starts with making the healthy choice the easy choice, and ideally an easy and sustainable choice. So something you find a little bit at least rewarding and sustainable. So the first place to start typically is changing your food environment, which is which foods enter your home. What do you buy? What do you order on grocery? Like, you can use DoorDash to your advantage here, because you can actually just pre-select. I'm going to only get these foods. They're going to come to my door this, twice a week. I'm not going to be tempted by walking down the aisles and, tempted by marketing ploys, right? You can decide what food enters your home. It's a little harder at work, but if you have a say at work, this is really important. Are we bringing in muffins and donuts and super delicious, easy to consume snacky foods that everyone can enjoy whenever they're stressed or tired or overworked or busy at work? Just mindlessly eating. This is a classic one. It's just, if you have a say in your food environment, in your occupation or your work, please make that as close to the healthy choice that will actually be eaten. No one wants to buy fruit trays and vegetable trays that won't be eaten, but you have to think about what will work for your family and your employees. Now, understanding your triggers, this comes down to understanding yourself, right? Sometimes the most profound changes come from the simplest realizations about yourself. And what systems are running on autopilot? You'd be shocked. I mean, maybe you wouldn't be shocked, but most of our days we're running on autopilot. We're just letting habits and simple associations run our behaviors. And so if you don't understand your triggers, you don't understand which habits are being played on autopilot, you're unlikely to change anything, regardless of how much willpower you have. Find new passions. This comes down to like hobbies, friend circles, things that get you outside, things that get you physically active in ways that don't feel like work. They feel like play. They feel like fun. They get you engaged in your life and provide purpose, but it's also a health promoting activity in some capacity. So if you think to your friend circle, the people that are in this crappy water environment, this crappy obesogenic environment, the people that are healthy weights and healthy metabolism are often people that are embedded. They have identities that are embedded in very specific healthy communities. And so I want you to embed yourself into those same communities. That could be community natural foods, right? It's those types of people you surround yourself with that you will most look up to and you will most likely emulate, right? So find the people in the communities that promote health as opposed to the other way around. And then address the root causes. So this is just obviously the recommendation to talk to your doctor, to work with practitioners, to identify the root causes of weight gain in the first place. Have you looked into hormonal imbalances? Is there any obvious trauma or mental health concerns? Is there any metabolic dysregulation that makes it incredibly hard to lose weight? Things like PCOS. You really need to work with somebody and then test and not guess when it comes to these things. And if you create a good team, get a good environment, you're very possible and likely, and I've had many patients who have come through not using medication at all, just change their environment, just change their lifestyle, just change the people that they hang around with. And then, of course, a couple of dietary tweaks and supplements along the way, who have lost enough weight to reverse their diabetes. I've had a few patients in the last 2 months that have actually done that, which is amazing. So anyways, just letting you know it's possible. And I'll stop with my lecture here in a second. My last one here is just thank you. Keep learning, keep experimenting, and test, don't guess. And reminder who my name is, Eric Nelson. You can find me at Nirvana Naturopathic Medicine. And then I have 2 recommended resources here. One is a video, and I literally was just sent this video today, and I thought it was excellent by a medical doctor that I work with, Dr. Brendan Gracious, and he sent me this video on YouTube. You're just going to search Dr. David Macklin, the gatekeeper, the go-getter, and the sleepy executive. If you don't remember any of that, even if you just put David Macklin, it's the only one that comes up. And it's a great 10-minute video, kind of describes a lot of the things that we talked about, just makes you think. Another book that came out, I think, December of last year, so it's pretty new. Dr. Salis Whalen, who's she's just one of the experts in obesity medicine. She's incredible. She obviously has a lot of humility and empathy, and she wrote a book that describes how to utilize the GLP-1 medications, how to think about them. So, okay, that's that. Let me come back. The first one here, what lab markers should be monitored while using these medications? For the most part, you're going to be tracking the ones that you're trying to improve. So those are the metabolic markers: fasting blood sugar, fasting insulin, HbA1c, your lipid panel, triglycerides. And then the markers you're looking out for side effects are the liver enzymes, any effect on gallbladder. So this is bilirubin, total bilirubin, and effect on pancreas. So amylase and lipase. So those are the things that I typically would recommend evaluating, adjusting, making sure that you don't have any elevations in those markers, and the things that you are trying to improve are actually improving. And then can you talk about GLP-1s and how it may help osteoarthritis? There is absolutely studies on this, and this is it's not as simple as just losing weight and therefore losing less pressure on the joints, right? People think of it as a mechanical problem. Like if you lose weight, then you will put less pressure on the knees, for example. And that's true, but obesity, it's a chronic inflammatory metabolic condition. So there's a very strong inflammatory component. And so these medications, or weight loss in general, will lower your chronic inflammatory markers. Actually, that's another marker that we would track, which is called HSCRP. And that's a marker you will see come down. And so you literally have less inflammation. You usually would use your joints more. People don't recognize how important that is in osteoarthritis. Is if you feel better and you do more activity, you are more likely to get more blood flow into the joints, right? Because you're getting more repetitions of flexion extension through the knee or the hip or the ankle or whatever you have arthritis in. So I think it's really important to think about this in terms of the GLP-1s are helping with weight, but they're also helping with inflammation because of you're getting rid of a chronic inflammatory stimulus. Okay. Any bone loss associated with these meds long term? Absolutely. So this is the same. So when I mentioned sarcopenia, I think, Kristen, you're spot on. I should have put sarcopenia, osteopenia, or osteoporosis, because they're one and the same, right? So they're, interestingly, in any weight loss trial, if you've lost weight, a lot of weight, whether that's natural or it's GLP-1 medication assisted, you will have bone mineral loss. And in fact, being obese or overweight is protective against osteoporosis, right? So it's one of the benefits of having extra weight is you actually have extra mechanical loading on the bones. Your brain is stimulated to maintain that. As you lose weight, you will lose lean mass. So this is the thing about strength training is you are doing strength training to prevent muscle loss, but also bone loss. It's equally as important, and especially important if you're using this as a postmenopausal woman, for example, especially beyond the age of 65. This is a huge thing. You need to be strength training and potentially talking to your practitioner about nutrients of concern that are related to the bones. Right, a bone-related supplement might be a great idea, a great add-on in that case, because you're probably not eating as much. You might not be getting a lot of the nutrients that are required, right? And you might also not be stimulating your bone as much because you're obviously 50 pounds down or 30 pounds down or 100 pounds down. You have people that lose 180 pounds. There's just no way of reproducing that bone stimulus. So you will have some bone mineral loss. Carlos says, after someone stops taking these medication, does the body sometimes continue the same pattern, such as reduced appetite, feeling very full? Okay, this is a really good question. So usually when people stop these medications, their appetite comes back. And oftentimes the recommendation is when you stop the medication, you actually titrate it down in a similar slow fashion is when you titrated it up, which could take months. And so it's important to know that. And you will have, often what happens is people will titrate down and they will notice that their appetite comes back. And if their appetite comes back to a point where it starts to become problematic, oftentimes the physician's saying, I don't want you to reduce your dose anymore, right? I want you to maintain this. And this is where a lot of people end up on a weight maintenance dose. And if you view obesity the way it should be viewed, which is a long-term chronic medical condition, you have to think about it almost like blood pressure, where you're just trying. In some people, they can do diet and lifestyle approaches and they can get their blood pressure perfect and then they can stay there. And that's true for GLP-1 medications and getting the perfect weight or an ideal weight. But in a lot of cases, we need to keep people on a small dose of a blood pressure medication so that they don't have their blood pressure go up, because that elevates risk and it's unnecessary. And so there's that part of your question. The pregnant piece, I didn't touch on pregnancy, fertility, baby's development during pregnancy, but these are not medications that I would recommend taking during gestational. In fact, you really shouldn't be taking them when you're pregnant, unless very specific cases, and you have to be working with a practitioner who does that regularly, because baby's development takes precedence over everything else during that time frame. So, and that also might extend into the breastfeeding time frame. So if you're breastfeeding, there might be a good use case to say, okay, we're going to go on GLP-1s, or maybe you were using them beforehand, but you potentially would want to start them 4 months or 6 months after you actually deliver the baby. So I would say the fertility piece is interesting, because if you use the medications before, fertility actually improves, especially if you are obese and you have a good amount of metabolic dysregulation and inflammation, chronic inflammation. All those things affect fertility. So if you get your weight down to an ideal body weight, you actually imprint on your future child epigenetic changes that are conducive to that baby having healthy weight for their life, right? It's one of the reasons why genetics are so important here, is that you are passing along your state when you're conceiving. So anyways, bigger topic. Sorry, I couldn't answer it in kind of detail there, Carla. So would you recommend these medications for someone with SIBO? If so, what can be done to increase gut motility? So no, I would not recommend these if you have SIBO. You have to treat SIBO first, which is a very treatable condition. You should be clear of SIBO within 2 or 3 months. And then once you're clear of SIBO, you can go ahead and do those things. But you have to be considered, SIBO can recur. And so if you struggle with constipation, functional constipation, you need to be on top of those things, because it's very possible that these medications would make it worse, and more likely that SIBO can come back. Now, we'll say one thing about the microbiome. I didn't mention this, but this trials on the microbiome using GLP-1s are showing a favorable shift, meaning that a lot of people are getting more Akkermansia, more bifidobacterium, more lactobacillus, more F. prosnitzia, like all the microbes that I looked at when I'm doing a screen of somebody's GI, like a GI 360, for example. I'm looking at these keystone bacterial species and I'm looking to see if they have them, if they have enough of them, and I'm trying to get more of them in the body. And GLP-1s seem to shift people in that direction because there's more fermentation happening. And that's actually a good thing. It's something that we're missing. But the case here with SIBO is no, that in my mind, I would consider that a relative contraindication. So we'd want to treat it first. Where's the best place to get these medications and be monitored? An obesity clinic. My family doctor is not very important about this. Oh, so tough. I mean, Maureen, do you live in Canada? This is not. This is something that if you don't have a very informed family doctor right now, you don't have like the pick of the litter. You can't just walk around and find a great family doctor. I would say there's so many good family doctors out there. So you could ask around. If you have any friends that currently are on these medications, they are working with a doctor that seems to be knowledgeable on it. I absolutely don't think you have to be an obesity specialist, but those patients or those doctors are going to be the best at this, full stop, right? But if you, there's also nurse practitioners that are very good, very qualified, and very common. They use these medications a lot, so it's really just about experience. And then, yeah, I would also recommend the book that I recommended, which is Weightless. I feel like it would inspire a lot of confidence in a patient to advocate for themselves for the right medication and why, right? So that's where I would start. My insurance does not cover these meds. Is there another way to have it covered? That's a great question, Maureen again. Yeah, so insurance is tricky. There's ways. So again, it's kind of interesting that your first question was about family doctor, because oftentimes this comes back to getting your family doctor to advocate on behalf of you on how it will affect your insurable risk, meaning that it'll decrease your blood pressure or your type 2 diabetes risk or things that will decrease your longevity, right? So you can improve to your insurer, if your medical doctor advocates on your behalf, that it is worthwhile of being covered. And then of course you can also shop around for different insurance plans or different versions of health spending accounts. I will say in this case, the generic medications will be probably available within a few months here in Canada, and it's going to completely change the game, because then it'll be $100 a month instead of 500 or 400 or whatever, right? So it ends up being very reasonable. It's not going to be pennies a day like a statin or a blood pressure medication might be, but it'll be, I think, hopefully less than $5 a day. That's the idea. So gestational diabetes. Oh, this is a great question. So this is, I would say there's some nuance to this question about whether or not you add on lifestyle adjustments during pregnancy if you weren't doing them before. So the conservative, super conservative answer is not really. The realistic answer is go find me a study that shows that exercise didn't make things better, right? So I usually would safely start with exercise there, and dietary approaches as well. The things that I mentioned about changing your food environment, changing, the types of hobbies that you have, exercise that you have. Generally speaking, it's hard to argue against those things and starting those things now, because if nothing else, you're actually more likely to improve your baby's health and improve your health along the way. Yeah. Okay, touch on potential cancers a little bit more. So there's two types of cancers that are known to be contraindications for this. So one is a specific type of medullary thyroid cancer. It has never been shown in human studies to be a relationship with GLP-1s, but it was shown in rodent studies in the preclinical trials. So specifically, I think with semaglutide. So the medications in a rodent do seem to increase your risk of a specific type of thyroid cancer. Interestingly, though, there is no contraindication to people that have existing thyroid disorders or any other type of thyroid cancer. So it's just specifically, I think it's called medullary thyroid cancer, and you can double check my work on that one. The other one is a rare, somewhat genetically determined type of endocrine disorder, endocrine cancer called MEN2. It increases your risk of a few different types of cancers. So don't ask me what it stands for. You can look that one up, but it's very specific. It falls into the same camp where there is a very small risk. Hard to say if there's any real signal in the noise in the current data in terms of like actual use. But I think there's going to be, it's interesting though, there's actually some trials on cancer risk reduction, and these drugs haven't been out long enough. But when you look back on 20-year data from liraglutide, for example, and things like that, you can see essentially like the safety over the period of time, the 2 decades, is very good. And then even the semaglutide has been shown to decrease risk of cardiovascular disease and very likely reduce the risk of colon cancer. Now, we don't know that for sure. It's too early because you need decades to really show that. But even within the 5-year trials on semaglutide specifically, they did show decrease what's called MACE, which is major adverse cardiac events, which is strokes and heart attacks and that kind of stuff. Cool. I think we did it. 808. That's not so bad.
Thank you, Dr. Nelson. That was a wonderful presentation. And just an FYI again, everybody, thank you for interacting and asking questions. And if you want to work with Dr. Eric Nelson, I did post a link to book. We offer complimentary discovery calls for anybody considering naturopathic care or just curious, want to reach out. You can use that link or share it with any loved ones who might be interested in learning more about our practice.
Thank you so much, Melissa. Thanks for everybody taking the hour of your days. And you get back to have a great sleep.